Okay, ladies and gentlemen, good afternoon. My name is Dr. Martin Henman. I'm going to talk to you about pharmacy and careers in pharmacy. Medicines are the most commonly used tool in modern healthcare. We use them both to treat serious disease such as diabetes and asthma, but also to prevent diseases and to prevent exacerbations of diseases. In addition to that, we also use them, of course, to treat minor illness and symptoms, things like athlete's foot. And of course, because we use so many of them, it therefore means that in actual fact, as a state, both as people and as the state itself, we spend a great deal on medicines. And in addition, of course, there are medicines which are used for other, shall we say, lifestyle or cosmetic purposes as well, which are also heavily used within the population. And it's this process of medicines use that pharmacists help within the health service and, of course, in terms of production of medicines as well. So pharmacy then is a profession, but it's also a science-based profession. So you have both the opportunity to work in the health service with patients, patient-facing role, caring for people and working with them to help them with their medicines and their diseases. But you also have the opportunity to work as a scientist in a laboratory or in the research area or in the pharmaceutical industry involved in the different aspects of work there. Pharmacy, like so many of the other health sciences, is of course an exportable qualification in the sense that it's recognised in other EU countries, particularly next door in the UK. And pharmacists work in a variety of settings, some in which they are, as it were, the boss in their own particular pharmacy, or alternatively for large companies of one sort or another. So there is something essentially for everybody within pharmacy itself. Today I'm going to talk about pharmacy, not just through itself, but also through the treatment of the illness of asthma. Because asthma is a common illness in this country. It's also one which is almost exclusively treated using medicines. And as you can see from the slide, unfortunately, despite the fact that we have a lot of medicines available, we know a good deal about how to treat the disease, there are still too many people whose condition is uncontrolled, and that leads to them missing school, missing work. But in addition to that, unfortunately, there are some preventable deaths every year, which really should not occur. We've always got drugs from lots of different sources, but particularly from things like plants. Because within plants, we know that there are a variety of highly active molecules, and if we can't use the plant itself, then what we can do is perhaps extract the molecule and use that molecule as a template to make new ones which will have specific actions, just one or two actions that we want, and to get rid of the rest. To do that, we use pharmaceutical chemistry or medicinal chemistry. So these sort of form two of the subjects which make up the pharmacy degree course. And of course, we need the chemistry as well, because having made a tablet or having made an injectable solution, we have to be sure that in a year's time or so, if it's been kept in a warehouse or a fridge or whatever, that in actual fact, the drug is still there, that enough drug is still there to do the job, and that there are no impurities or other things have occurred to it. Pharmacology tells us about how the drugs work. So looking at cells, looking at tissues in tissue culture is a way of us doing that. But because most of the targets through which drugs act are proteins, it means they're coded for in genes. So we can use genetic analysis as well to help us look at the molecular level as to how drugs work and therefore attempt to devise better ones on the basis of that mechanism. Now, if we take the example of adrenaline, which is not necessarily a drug in some senses because we all make adrenaline. Adrenaline, of course, we produce at times of fear and anxiety, such as before giving a lecture on open day, for example. And what it does, of course, is it speeds up the heart, but at the same time it also opens up the airways. Because when we were in the Stone Age or whenever, we used to have to run away from things that wanted to eat us, and so therefore we needed something to help us do that, and adrenaline is the molecule that does it. Originally, adrenaline was used to treat asthma, but the fact that it speeds up the heart as well as opens up the airways is a problem. I don't want to start a child who has asthma on adrenaline and give it to them every day for the rest of their lives, because every day it's going to stimulate the heart unnecessarily. And I can't afford to have that stimulation occurring. So really what I want to do is to take adrenaline and turn it into a molecule which only works on the airways. Nevertheless, adrenaline still does have some uses, because in certain emergency situations, the sorts of things you see on Grey's Anatomy, in which they're pushing somebody on a trolley through the corridors and shouting at each other about getting epinephrine stat. Epinephrine is American for adrenaline, and stat is immediately. right? So that's when it's used. And as you can see, we also provide these adrenaline-containing pens to patients who have allergies, in whom the allergy occurs very quickly, say from bee stings or something like that, and becomes almost overwhelming. And to get them to hospital, they need to use their pen, put it in subcutaneously, and that will get them, with any luck, as far as the hospital where they can be properly treated. But we go back to our adrenaline and our asthma. If we take that adrenaline molecule shown on the right-hand side of the slide there, the small molecule, and we systematically modify it, we can then turn it into one which has primarily effects in the lungs and almost leaves the heart alone. And that's exactly what we want to do. And when, as pharmacologists, that's tested, the two graphs here, on the left, it shows the effect of the drug on the lungs. And as we move up that dose-response curve, we're increasing the amount of drug which is used, and the straight part in the middle represents the range, the therapeutic range at which it would normally be used. And the great thing is that even when we go above that, if for some reason or other we take an overdose of it, the top part of the curve, the top of the bell there, in actual fact doesn't overlap with the next curve. And the next curve is the one in which the drug produces its effect on the heart. So it's producing it at higher doses, and the doses are sufficiently high to mean even in overdose, it should have a minimal effect on the heart at those high doses. And the bulk of the effect is almost entirely in the lungs, where we want it to be. So that's one way of making the drug much more selective and therefore more effective physiologically. Now, asthma is a relatively complicated thing. We used to treat it primarily by looking at the symptoms at the bottom here, which is breathlessness and wheeze, the things that everybody associates with asthma. For that, when we used the Salbutamol, which is a bronchodilator, to treat that, that's fine. But you can see in the middle, just above that, the inflammatory process. This is the actual fact, the thing which is driving the asthma. So therefore, if we want to stop the asthma from progressing, and we want to make sure that a patient who starts to develop asthma when they're young, still 30 or 40 years later has a reasonable pair of lungs to work with, we need to stop that inflammatory process. So we need to use some drugs which will halt the inflammation and at least contain it in order to keep them healthy. Corticosteroids are the most powerful anti-inflammatory drugs we have. They're extremely effective whether the asthma comes from allergy or it doesn't come from allergy. And they work well in asthma. The difficulty with them is that they have a lot of other effects in the body too. So we don't really want to give them in tablet form to patients because in actual fact we'll see a lot of those other effects. And it turns out that we can't modify the structure as we did with adrenaline to turn them into something which is selective for the lungs. So that means we're going to have to take an alternative approach, and we'll see what that is in a minute. Now, having said that asthma is quite a complicated disease, a disease that people very often think is closely related to it is bronchitis or chronic obstructive pulmonary disease. But it turns out when you look at the pathophysiology in the diagram there, that COPD, which is mostly caused by smoking and irritants, isn't the same sort of disease, and although steroids work, they don't work anywhere near as well in those patients. So when we come to talking to patients who have COPD versus those who have asthma, we have to educate them in different ways about the importance of the various drugs that they have. They're both going to take salbutamol to keep the lungs open, but the asthmatics are going to need to take their steroids to stop their disease from occurring. The bronchitics are probably only going to use the steroids occasionally, and much less commonly. In order to talk about what goes on in humans, of course, we need to look at clinical pharmacology, because before a drug can be authorized and released into the market, it has in actual fact to be assessed in humans, in clinical trials, structured experiments. And as you can see from this, because we've got the bronchodilators and the corticosteroids, we're going to need to work with combinations of drugs. And we need, as you can see from the diagram at the bottom there, to differentiate perhaps between the acute circumstance in which the patient is actually experiencing the asthma at this time and the preventative one. In other words, a lot of asthma patients can go a long time in between attacks, but we need them to take the drugs in between the attacks in order to keep the disease under control, because we can reduce the frequency of those attacks by doing that. Now this, from clinical trials, looks at the effects of two drugs. On the left-hand side, the three curves show each of the two drugs at the bottom, the green, then the blue separately, and then the combined pair administered together at the top. And you can see that they all work, but you can also see that the combination actually works better when you put the two together. On the right-hand side is a number of weeks later. And when we look at that, what we see is that in actual fact, the blue line has fallen down. So the drug with repeated use has become slightly less effective. It's still effective, but it's less effective than it was before with that repeated use. But if you look at the mauve line is telling us the good news, which is that using the combination, in actual fact, both drugs continue to work at their maximum effect. So in actual fact, it's not enough to say, well, we should use that one and then we'll use that one. We actually want to put the two of them together and use them. And of course, pharmaceutically, that takes some doing. The ways in which we do that, there is another subject in the course, which is pharmaceutics and pharmaceutical technology, looking at how to combine drugs and how to deliver drugs to particular places in the body. So we've got at the very top there the preparation of intravenous materials, in the middle then transdermal patches driving drugs into the skin and then into the blood from there, and then at the bottom an insulin pump putting drugs in underneath the skin in a subcutaneous pump in response to the amount of sugar in the blood. So that's a way in which we do it. For our asthma, we want to deliver them directly into the lungs. Now, if you're looking for a Christmas present for somebody, here is a rather old and expensive antique, which is a way in which people used to take medicines. They used to put the powder in there and then tip it up and swallow it down into the body. And this is an old inhaler. You used to put in here a variety of herbal materials, which when heated, if you put it into hot water, will then make all of the vapours come off. And as the vapours come off, you put your mouth over the spout end there, suck it in and draw it into the lungs. So it's like menthol, and it goes in and helps with the breathing. We, of course, can do a little bit better than that now. We can use things like inhalers. And in particular, of course, it's going to be very important for our steroids, because we don't want to fill the body with steroid. We only want to get it into the lungs. So inhalers, therefore, end up looking something like this. And the key to this is that, in actual fact, we have this small container, which in actual fact is pressurized. The drug is in there, pressurized as a gas, turned into a liquid. And when it works against the valve then releases a dose. And of course, one of the other key things to this is that this holds 200 doses. And I need the patient to know that when they get to dose 199, there's as much drug coming out in that dose as there was when they used it at dose 1 or dose 2. Okay? On the right-hand side, then, you can see the effect of the size of the particles. So even the droplets in here need to be within that 2 to 5 micron range, because I want them to go into the middle part of the lungs, not to the very bottom where we exchange the oxygen and the carbon dioxide. Because if they go there, the drug will simply disappear off into the blood and away around the body and not really act in the lungs at all. So that's quite important. And in order to do that, we've created lots of different types of inhalers. These two work on the basis of powders, things that we can't turn into gases and put into pressurized containers as solutions. So these ones contain, in actual fact, within there, a variety of, a series of doses. I operate the device to actually open up the dose, put my mouth over the end here, breathe in, and that's how the drug gets in. And then in this one, it goes in as a capsule, which is fitted into the body of the thing here. I simply put the top on, break open the capsule using the device at the side, and once again, suck in through there, and away goes the drug into my lungs. But the drug is in there in particles of between 2 and 5 microns. And irrespective of the fact that this might sit in my cupboard for several months, at the end of it, those particles won't have stuck together. So they'll still all be free-flowing and 2 to 5 microns. So the type of technology that gets you to be able to do that forms part of this subject. So we have the technology and we have the drugs to deliver to patients. But there is still other things we need to talk to the patients about, how to use them and what to do when things are going wrong. So here is my inhaler. You can see here that in actual fact we've got a little device there for a child, a spacer, which is in order for me to be able to put the dose from here into that little chamber, and then they can just breathe it in. Because the alternative is this, so I'll demonstrate how we usually use these. I therefore got ready by, in actual fact, stopping the speaking, got ready to take a deep breath, timed the deep breath to coincide with actuating the inhaler, took the drug in the lungs, held it there for a count of 10, and then let out the breath through the nose. So I kept as much as possible in the lungs and allowed the drug there to work. If I had carried on speaking, I would have just puffed all of the drug back out again as I was talking my way through it. And so patients have to know how to do that. And for children and for older people for whom that coordination is difficult, we therefore have devices like this to help them. This kind of work of talking with patients about what their drugs are for, how they work, and how the devices themselves work and how they're to use them, we talk about as the practice of pharmacy. And you can see here our previous Minister for Health is being shown around our facility for doing this, in which we have a model pharmacy in which we videotape students playing either the part of a pharmacist or the part of a patient, and you can see she's not really very interested. But that's life, you know, sometimes you just don't win. We also, of course, in actual fact, the pharmacist therefore has responsibility for doing this in law, and so they're supposed to do this. And it's very easy for us to say, well, that's okay, because the medicines are fairly straightforward, everybody knows what to do, don't they? But in actual fact, the three bottom points on the slide show you that isn't true. A study looking at what's called health literacy, the ability to use information which is found on medicines or in documents produced by the health service, and to act on it for your own benefit, your own health benefit, showed that when people were given packs containing aspirin with the typical labelling which is on the pack, that 24% of people in this country couldn't work out when they would need to see a doctor in certain circumstances. Compared with Sweden, in which there was only 6% of people couldn't do that. The UK and Australia were very similar to Ireland, but there were some countries that were so bad, so much worse than Ireland, that their governments refused to allow the researchers to publish the information. So that means when we're talking to patients, we cannot assume that everybody is the same as us, that we have to make sure that everybody can get the message. One of the things that we will want to do, of course, is to help patients to monitor their condition, because when asthma gets worse, I need to take additional medicines in order to stave off the attack and to limit how bad the attack can be. And this device, which is called a peak flow meter, helps me to do that, because it records how well I can breathe out, and that, when those numbers start to change, tells me that an attack is coming. So if I just puff into here, with any luck I should get a value of about 500, and if I do, that's okay. If it's less than that, I'm in trouble. So, rock on. That's good. Right, so I shall live to see another day. These things here we use with all sorts of people. So children are very good with these because they're quite happy to puff into there, get the number, record it, and see what's going on. The reason we need that is because we have a variety of people to teach, so we have to be able to teach anybody, and we can teach anybody, really, we can. If we look underneath that, however, you can see these are the typical numbers going by age and by gender for men and women, right? So the top of the men, underneath that the women, and age is going from left to right. So as we get older, our lungs begin to wear out a bit, so the numbers go down. But those are the numbers we would expect to see. On this little diagram here on the right-hand side, the yellow, the green rather, means that I'm in good health. Things are fine. But what's happening during the day is that in actual fact, I'm coming to the point at which I might get an attack. And that's these dips down into yellow and then into red. The great thing about the peak flow meter is, because it records the numbers, my ability to blow out, as those numbers start to fall, before I get the symptoms, this is telling me an attack is coming. So then I could take the medicine and take it early on enough to actually prevent the attack from really developing. So it's not all quite as straightforward as it seems. Now, apart from talking to patients, obviously, about their medicines and their condition, the patients have to fit these things into their lives, irrespective of what it is that they're doing. And sports people in particular need, in actual fact, to be able to work out which medicines they can take and which they can't, because some they're allowed to take and others are banned. So they have to have an understanding of that, both not only with their prescribed medicines, but also with over-the-counter medicines, stuff they can buy in the pharmacy or even perhaps in the supermarket. So pharmacy then represents a degree course in which we teach the pharmacy modules from the first year all the way through to the final year. We teach it in a variety of ways. Lectures like this, traditional laboratory work with chemistry and so on, but then also the videotaping in the communication skills that I showed you. We also use visits to industrial sites and to hospital sites and to community pharmacies, and there's work experience during the programme too. We also have people who work as pharmacists in the health service and in the pharmaceutical industry and elsewhere come in and talk to students about the work that they do and in actual fact give them advice about helping to get started in their careers. And as you can see on the top left there are other things which are done in pharmacy such as five-a-side, and on the right hand side some good-looking people who went to the pharmacy ball. So it's a 4-year degree then to do pharmacy. Within that time, you learn all of these different things, and you can work in any of the areas, community, industry, hospital, whatever. You don't specialise into becoming one, you have the capacity to work in all of them. At the end, you need to do a year for an MPharm, which makes you a pharmacist, and that's also done partly through work in a patient-facing centre like this. We have two of the largest teaching hospitals in Dublin, with St James's and Tala, and we also work with other hospitals in and around the country. In addition to that, we work with all of the big groups in pharmacy and also a lot of the independent pharmacists who have their own pharmacies, and we work with them both in the course and also when our students go to them. In addition to that, there are other areas in which pharmacists work, such as the healthcare management shown here, the Pharmaceutical Society of Ireland, which is the regulator, obviously the Department of Health and Children, but also another body which isn't on the slide, the Health Information and Quality Authority employs pharmacists, looking at how well medicines are used in the community and looking also, of course, at when things go wrong. But in addition to that, medicines are, in order to license these medicines and put them on the market, you have to produce a set of information for the Irish Medicines Board, because everything which appears on the market must be approved by them. And so therefore they use doctors, pharmacists, vets to look at human and animal medicines and to assess whether they're effective and safe and should go onto the marketplace. In addition, we've attracted to this country virtually all of the top 10 pharmaceutical companies, whether they're making traditional chemicals or whether they're biotech companies. Most of them are here, and they employ graduates such as ours in their businesses. We also have an extensive research program going on in the school. We have some talk courses in community and hospital for people who want to specialise in those areas once they've qualified and started to practice. These are mostly distance learning and part-time courses. And then we have research degrees through all of the different types of subjects that I've spoken of. And we have connections both inside and outside the college with other big research groups and industrial groups as well. So that really therefore means that you have the possibility to work in all sorts of areas without specialising in pharmacy, any particular one, and to choose the things in which you will work. But of course there is one last thing which in actual fact we didn't quite touch on, which was in the title. So if you want to know, we look forward to welcoming you. So, Guru Mila Machagat, thank you very much. If you have any questions, please ask them. Thank you.